You can stop sharing now. Yes, thank you. Can we start, Mitali?
Yes, yes. Sharmila, please start.
Yeah, thank you so much. It's an honor to invite you all for the Journal Club for the month of May. And we are extremely happy to have such a prestigious institution, the Bharatiya Vidyapith University from Pune, joining us. And I would like to thank Dr. Girija Wag, the coordinator. And I would like to welcome all the faculty who are joining today, the delegates. And a special welcome to our chairperson of FOGSI ICOG, Dr. Lakshmi Shrikande, who's responsible for such a great academic program. And she's responsible for so many academic programs which are happening in ICOG every day. And we can see the visible outcome in the postgraduates as well as the young clinicians who joined for this program. And I would like to welcome the senior faculty who joined, Professor Gus Decker, the international expert. Thank you so much, sir, for joining. I'd like to welcome Dr. Girija Wag, the coordinator, Dr. Aniket Kakade, who will be the MOC today. I'd like to welcome all the faculty, the presenters, as well as the experts who are joining from in the Indian College, Professor Palniyappan and Dr. Bharati Maheshwari, as well as my co-convener, Dr. Ashwini Balarao Gandhi, and all the delegates who joined. We are not, our program will never be a success without your participation. Thank you so much. May I now request Dr. Aniket to share the CV of Dr. Lakshmi Shrikande, please. Dr. Lakshmi Shrikande, madam, does not need any introduction to any person in FOGSI, but it's my honor to introduce her. She's a chairperson of the FOGSI ICOG, and she's a national corresponding editor of Jogi. She's been the national corresponding secretary of the Association of Medical Women of India. She's received several awards. She was a senior vice president of FOGSI in 2012. She's delivered almost 11 orations and 450 guest lectures. Her publications are almost like 39 in national level and 11 international publications. My request, Dr. Lakshmi Shrikande, madam, to say a few words before we start the academic session. You can stop sharing, Aniket.
Yeah. Thank you. Thank you so much, Charmila, for your kind introduction. Friends, I'm so happy to be back with you all once again with this monthly journal club. And on behalf of ICOG, I would first like to welcome our international expert, Professor Gus, who has logged in from Adelaide. So, sir, welcome to India, though virtually. Yeah, most welcome. And I also like to welcome our national experts, Girija Wag, Vandana, Professor N. Palniyappan, and Dr. Bharati Maheshwari. I'm so happy that this time Bharati Vidyapith from Pune, they have joined, and their postgraduates will be presenting 3 cases. First will be, they will be presenting 3 papers. First will be on optimum timing for labor induction after PPROM. Second will be letrozole, a novel treatment for ectopic pregnancy. And the third paper will be conservative surgery for ovarian torsion in young women. So I'm so happy that Charmila has chosen the institution and the papers. Very good selection, Charmila, and along with Dr. Ashwini Balarao Gandhi, they both are doing so good work for this monthly journal club. So I express my gratitude to the convener and co-convener, and I take this opportunity to welcome all the dear delegates who have logged in for this journal club. So without wasting much time, I hand over back to Charmila for further proceedings. So let's have happy learning for we all. Charmila, please start.
Yeah. Thank you so much, ma'am. Thank you so much. May I have the CV of Dr. Girija Wag? I would also like to welcome Professor Vandana Nibargi from Bharatiya Vidyapith, as well as the presenters, Dr. Prachi Prasad, Dr. Shivani Bandari, and Dr. Shruti. It's an honor to introduce Dr. Girija Wag, who's a coordinator for this program. She's a professor and HOD, the Department of Obstetrics and Gynaecology at Bharatiya Vidyapith Medical College Hospital, Pune. She's a senior consultant at Cloud9 and Apollo Hospitals, Pune. She's a faculty professor for FOGSI, international expert, general coordinator. She's actually the vice president-elect for 2024, which is not mentioned in her CV. As usual, she has forgotten all her important achievements, and we know most of her achievements. She is such a great person to work with and a great academician, and her inputs are always welcome in any academic forum. May I request Dr. Girija Wag to say a few words before we start the academic session?
Thank you, Charmila. for that very kind introduction. And it's really a privilege for my students to be able to present their work at the ICOG forum. And I think it has a great prestige to us as an institution. And plus to have Professor Gus Decker here, because I must tell you that in my last tenure as the head of the department, Professor Gus was our international mentor for the department. And he guided, 2 batches of my PGs for their dissertations. He is such a humble person, and his CV, if we go through, is something that we all have to reach to that pinnacle in life of research and development and understanding and sharing with the community with the sort of expertise and experience that he has. And therefore, I really thank Lakshmi and Charmila for giving us this wonderful opportunity so that we can have such kind of a wonderful academic program where students get to connect to stalwarts, not only in the national community, but also in the international community. And we look forward to this kind of an opportunity time and again. Thank you so much.
Thank you, Girija. Can I have Anikit's CV, please? Anikit, your CV, please.
Nothing. I will only read my CV as such. I am Dr. Anikit. I am working as a professor in Department of Obstetrics and Gynaecology. Dr. Girija Bagh, madam. I am a consultant and I have done my fellowship in high-risk pregnancy and critical care in obstetric. And we both lead the 6-body dedicated obstetric HU with something a unique office counts. We only see it's a dedicated thing for obstetric high-risk patients wherein we manage them. And we also look at the critical care obstetrics, and we have got an obstetric ICU with us. I am visiting consultant at nearby nursing homes and have a few publications under my name. That's all from mine. Thank you.
And we have seen your dedication, hard work in the UNICEF program, which you did for us. Thank you so much for that. May I now request you to introduce the international experts and all the national experts before we start the academic session. I hand over the sessions to you. Thank you so much, Anikit.
Yeah, from the ICOG, we have got Dr. Charmila, who is the Vice President-elect of FOGSI 2024, Chairperson of the Clinical Research Committee in FOGSI, ICOG Governing Council Member 2123, a National Coordinator for UNICEF, National Coordinator in the Mega FOGSI program, and the ISAR Gurukul. She is a member of WHO, CRO, and MDSR. She is past Secretary of Trichy OBGY Society and President of Menstrual Hygiene Management Consortium of the FOGSI and Joint Secretary of the Gestosis. Dr. Ashwini Baljarao Gandhi, ma'am, who is a consultant gynecologist at the PD Hinduja Hospital, Mumbai, National Joint Treasurer for the Indian Menopause Society, President of Mumbai Menopause Society, Vice President of FOGSI 2013, President of MOGS 2012-2013, ex-associate professor in Nair Hospital and Topiwala Nair Medical College, Mumbai. He is a consultant gynecologist and he is a part of the first of a sort Valva clinic at PD Hinduja Hospital in Mumbai. Dr. Lakshmi madam is already introduced by Dr. Charmila. Then we have Dr. Suvarna Khadikar madam, who is professor and head of the consultant endocrinologist at Bombay
Anikit,
Hospital.
you can make it very short because we need to start the academic program.
Okay, she is joint secretary of MOGS, and we are knowing her since long. Dr. Geeta Palsarkar madam is the editor-in-chief of the Yogi Journal, and we have come across when we have sent our journals, we have got communication from the desk of editor-in-chief, and that was Madam for us, treasurer of MOGS and past president and president of Menopause Society. She is of course a very good teacher and she is a professor at GS Medical College, and she heads the unit in Nauroji Wadia Medical College. The experts for today is Professor Gus Decker. Professor Gus Decker is the academic head of Department of Obstetrics and Gynaecology at Northern Adelaide University of Adelaide. His area of specific interest include genetics and immunology of preeclampsia, prediction, prevention, and management of preeclampsia, prediction and management of preterm labor, genetic, acquired thrombophilia, causation of adverse pregnancy outcome. Professor Gus was the clinical and lead investigator of the Australian arm of the SCOPE Consortium. The University of Adelaide had developed a predictive algorithm along with fetal medicine. In Australia, Dr. Gus Decker's unit was the first to use the placental growth hormone for measurement in the management of pregnant patients in hypertension. He has got a huge amount of research funding, and his publications over his career has got whopping 380 peer-reviewed papers, Google H index of 92, which is something which is just too good, sir, and a huge citations of 34,464. And he is the right person, I think, after looking at his academic association, to be an international expert for the students in Bharati Vidyapeeth. Dr. Nimbargi Madam is the professor and she heads the 3rd unit in Department of Obstetrics and Gynaecology at Bharati Vidyapeeth Medical College, Pune. She also works as a consultant in obstetrician and gynecologist with 30 publications under her name. She is a core committee member of RNTCP and a ex-core member of NAC of our institute. Well, it is a pleasure and honor to introduce Dr. Palaniappan. Sir is professor and unit head in Department of OBGY at Ramchandra Medical College. He has won N number of awards. He is a senior overseas fellow for Liverpool Hospital, Sydney, and renowned orator and young gynecologist award of AOFOG. And he is the president of Obstetrics and Gynaecology Society of South India. And he is chairperson of Safe Motherhood Committee, FOGSI 2017-2019. Warm welcome to you, sir. The other expert that we have today is Dr. Professor Bharti Maheshwari. Madam is professor and head department of OBGY and IVF at Muzaffarnagar Medical College at Muzaffarnagar. He is chairperson of FOGSI MTP committee and having fellowships and governing council members and many role to play, a multifaceted personality. President of Meerut OBGY, has authored many papers, published many papers, delivered many orations, and organized N number of conferences under the aegis of FOGSI and the local bodies. So a warm thank you to all the ICOG members, to all our international experts, to the experts. And I think we can go ahead with the journal club.
Yes, yes, Anika.
Yeah, so the first case for today, we are having an article called as under the label of optimum timing of labor induction in patients who are going to be having after rupture of membranes. It's a secondary outcome study of the term PROM. This study again,
meantime, you can stop so that they can share their screen. You can stop screen sharing and the PG can share.
Yeah. So they can share the screen in
meantime,
this article came into picture as a secondary outcome of the term PROM study.
You share your screen, postgraduates,
So we are hearing this article, term PROM study many times during our clinical discussions. And Dr. Wang Madam also thought we should be able to throw some light on this wonderful study. And for presenting this journal article, which was published in American Journal of Obstetrics and Gynaecology 2023, Dr. Prachi Prasad is second-year resident in the Department of OBGY at Bharati Hospital and Bharati Vidyapeeth Medical College. I request Dr. Prachi to please present the GC.
Good evening to one and all present here. I am Dr. Prachi Prasad, junior resident, second year in Department of Obstetrics and Gynaecology, Bharati Hospital, Pune. Let's proceed with the paper. Title: Optimal Timing of Labor Induction After Pre-Labor Rupture of Membranes at Term, Secondary Analysis of the Term PROM Study. This article published in American Journal of Obstetrics and Gynaecology in September 14, 2022. This is the main research article. Objective: the study aimed to identify the optimal timing of labor induction in women with term from pre-labor rupture of membranes by comparing the maternal and neonatal outcomes associated with labor induction with those of expected management at any given 1 hour interval following pre-labor rupture of membrane. Although there were no differences between the groups in the primary outcome of neonatal infection and in the rate of cesarean delivery, women who underwent immediate delivery with oxytocin had a lower rate of clinical chorioamnionitis and ever than those allocated to expected management with subsequent induction with oxytocin. Pre-labor rupture of membranes occur in approximately 8% of term pregnancies. Its associated complications include maternal and neonatal infection, cord prolapse, placental abruption, neonatal asphyxia, as well as increased risk for operative deliveries. The optimal management of women with term PROM with regard to the timing of labor induction remains unclear. Expected management may increase the likelihood of spontaneous onset of labor, can potentially reduce the duration of admission and use of resources, and was previously thought to decrease the risk of cesarean delivery. The main concern regarding this strategy, however, is the risk of neonatal and maternal infectious morbidity, which is known to increase progressively with the time following PROM. Therefore, induction of labor either immediately or within a specific interval following PROM is often the preferred approach in an effort to decrease the risk of infection. The best source of evidence regarding the management of PROM at term is the term PROM study. This was a large multi-center randomized clinical trial of women with PROM at term who were randomized to immediate delivery with oxytocin or prostaglandin E2 gel, or to expectant management for up to 4 days that was followed by labor induction with either oxytocin or prostaglandin gel. This was a secondary analysis of data from the term PROM trial, an international multi-center randomized clinical trial on immediate delivery versus expectant management of women with PROM at term. All participants are considered as a single cohort of women with term pre-labor rupture of membranes, irrespective of the original randomized study group allocation. For each given 1 hour time interval within the first 36 hours following PROM, outcomes were compared. Primary neonatal outcome was a composite of neonatal infection and admission to the NICU. The primary maternal outcomes included maternal infection like clinical chorioamnionitis, postpartum fever, and cesarean delivery. Briefly, 5,041 women with a single fetus in cephalic presentation who presented with PROM at 37 weeks of gestation were randomized to one of the 4 groups, namely immediate induction with oxytocin, immediate induction with prostaglandin E2 gel, expected management with subsequent induction using oxytocin, or expected management with subsequent induction using prostaglandin gel. Women in the 2 expectant management groups underwent labor induction if labor did not occur within 4 days from presentation, or in the case for maternal or fetal indication for delivery. Inclusion criteria: women with PROM at term. Exclusion criteria: active labor at presentation, previous failed attempt to induce labor, contraindication for vaginal birth such as placenta previa, contraindication for expectant management such as meconium staining of the amniotic fluid or chorioamnionitis, previous cesarean delivery, missing information regarding onset of labor, time from PROM to labor exceeding 7 days. So the original trial groups were divided into 4 groups. First group, induction with oxytocin. Second, induction with prostaglandin. Then 2 groups were expectant group with oxytocin, expectant group with prostaglandin. The overall cohort of 5,041 taken, in which exclusion were previous cesarean, missing data on onset of labor, missing data on PROM to labor interval, and PROM to labor interval exceeding 7 days. So the eligible cohort came to be 4,742, in which spontaneous onset of labor and labor induction were there. Outcomes. The primary neonatal outcome was a composite of at least one of the following: definite neonatal infection, probable neonatal infection, or admission to NICU. In addition, 2 maternal outcomes, namely a composite of maternal infection consisting of clinical chorioamnionitis, postpartum fever, and cesarean delivery. Secondary outcomes include NICU admission, time from PROM to delivery in hours, and total duration of maternal hospital stay. In addition, for women who were managed expectantly and did not undergo labor induction, we calculated the cumulative proportion of spontaneous onset of labor as a function of time from PROM. So this is the graph. It shows time interval from PROM to initiation of induction among women who underwent labor induction. The red line indicates the median time from PROM to induction was 8 hours 20 minutes for women who underwent one of the immediate induction groups in the original trial, and the blue line indicates 46 hours of median time for those who were allocated to one of the expectant management groups. Of the 5,041 women included in the original study, 4,742 met the study criteria. Of those, 2,622 underwent labor induction and 2,120 experienced spontaneous onset of labor. The baseline characteristics and outcomes of women who underwent labor induction and those who were managed expectantly were overall similar, except for a higher rate of birth within 24 hours following PROM among women who underwent labor induction. So this is the overall result. PROM to delivery interval in labor induction group is 23 hours and in spontaneous labor is 26 hours. In ICU admission, 15% in labor induction group, 15% in spontaneous labor. Chorioamnionitis, 6% in labor induction, 7% in spontaneous labor. Cesarean delivery, 9% in labor induction, 8% in spontaneous labor. Total maternal hospital stay, 80 hours in labor induction, 79.5 hours in spontaneous labor. In summary, it's found that among women with term prom, neonatal and maternal risk increase progressively with time from prom, and that early induction of labor within the first 15 to 20 hours is associated with a reduction in neonatal and maternal risk when compared with expectant management without affecting the risk for cesarean delivery. Based on these findings, immediate labor induction seems to be the best management strategy to minimize neonatal and maternal morbidity in cases of term prom. In cases for which immediate induction is not feasible, labor induction remains the preferred option if performed within the time window of the first 15 to 20 hours following prom. These findings are highly relevant for patient counseling and to guide management protocols in accordance with local availability of resources. Strengths of this study: large sample size, detailed information that included timing of events, that is prom, induction, onset of labor, strict definitions and blinded assessment of maternal and neonatal outcomes, provide estimate of the neonatal and maternal risk associated with induction versus expectant management at 1 hour intervals following prom. Finally, the risk for the study outcomes in cases of induction versus expectant management were adjusted for potential confounding variables. Limitations: despite the relative large sample size, the current study was underpowered to analyze uncommon outcome in relation to time from prom. Although the allocation of women in the original trial for action versus expected management was random, some women allocated to expected management could have undergone labor induction earlier than planned for maternal or fetal indications. Given that routine vaginal examination at presentation was avoided at the time of original trial, information on cervical dilatation at presentation with prom was missing for a large proportion of the cohort. Therefore, we did not consider dilatation as a potential confounding variable. Finally, this trial was published approximately 25 years ago and may thus not reflect the changes in obstetrical and neonatal care that have occurred since then. Thank you.
You can stop sharing, huh, Prachi?
Yes, ma'am.
Aniket? Girija, would you like to say something? Your inputs before we start the discussion.
So this article was a secondary outcome of the term prom study, wherein there was a large sample size. Sample was very significant. That was an strength of this article. And then this secondary outcome was standing.
Yeah.
And we can have questions from the experts straight away.
Yeah. So anything you want to add, Prachi, before you are asked questions? Or you want to be anything else you would want to express?
You can proceed.
Okay. So the experts can ask the questions. Professor Gus? Dr.
Yeah,
Vande?
thank you. So you can hear me? It's a clear line, yeah?
Yes,
Good.
Yes, sir.
So I think this was very well presented. It's of course a very interesting publication if you think that the Hannah trial was 1996, so
Yes.
that's 27 years after the trial. And I don't know if we, because it's not an exam for our young resident who's there, but I think it's good to, I think some practice points have changed, of course. In those years they used, and probably also in the Australia, I moved to Australia in 1998. Australia was quite late with moving from prostaglandin gels to PGE2 pessaries, which our commercial name is Cervidil. Because if you, and I think there's some relevance there, that if with the gel you have repetitive, let's say, at least vaginal examination, and the placement of the gel with the pessaries and one-off, I think that is let's say a real relevant change. The other thing is, of course, this is a study from the mid-90s, and it's interesting to see how low their overall cesarean section rate was. We would have great effort to have our cesarean section rate that low. So I think that it in those years, it's clearly showed how there was in the mid-90s, there was a strong bias against induction because people did see the association with cesarean sections. And it took a long time for us to realize that it was not the induction that caused the cesarean section. There was all these induction of labor trials was in women with comorbidities, and that was driving the cesarean section rate. And we now know that the induction of labor, there's a cost aspect, but it's definitely not increasing the cesarean section rate. I think if you look at the authors, it's a very creative use of the data that you have this RCT, and now you just start to approach them as one group, and you just do this interesting type of analysis where you just look at the shift in morbidity per hour, which I think is I think it's a good reminder that if you do any big RCT, big numbers, there's always clever secondary analysis that you can do. So it's a good, if you think of let's say, of making publications. Purely from a clinical perspective, this publication did not have a major impact on our clinical management of term prom, because we already basically, our bias was already, when you have a prom term, advise the women to be induced. Typically, our practice is that if patients come in with ruptured membranes close to term, not in labor, we give them about 6 to 8 hours and then to get established. And if nothing happens, we said we really want to see you at about 12 hours, because then we'll start with both antibiotic and basic induction of labor with the unfavorable cervix. So we do a one-off vaginal examination at that stage, because we decided to continue with labor. Then we will use Cervidil, the PGA, pessary, and if they're more favorable, we do oxytocin. So that from that perspective, this secondary analysis did not change our management. And I think it clearly demonstrates that if you wait longer, there's a real increase in the risk from maternal inflammatory conditions and maternal morbidity. And that also brings me to a little bit of the further flaws or criticisms on the study. They had GBS data, and they mentioned actually that they had Group B streptococcus data, and it would be because in this one of the secondary analysis of the Hannah's trial, the original one, and I'll check the year was, that was the GBS follow-up, that was, yeah, in 1997, also American Journal, they did a sub-analysis for the women that were GBS positive. And it actually got much less attention, but that showed that if you have a longer interval, it's not a surprise, if you have a longer interval and you're GBS positive, then you do see more neonatal infections. And I think that it is a pity that they did not take that opportunity on this analysis also to look at that particular aspect, because they had the data, and it would also there is also secondary analysis in the mid-90s on costs. Now that's a cost from the North Americas, where actually at that stage there was not a big costing difference, but obstetrical care has changed, costing has changed. It would have been, for this type of analysis, it would have been good to see, let's say, health technology assessment. When they looked at cost, that would have been a good aspect for this study. And perhaps that might still come. It might be that they used the so-called salami technique, that they cut the data in lots of slices to get more publications. That could well be. And there was also in those years, there was analysis on the group of women that was managed at home, and that aspect was also not specifically highlighted in the home versus hospital management. That was published also in 1997. There was a higher percentage of adverse outcome in the home management group. And I think they could have done that secondary. So it's a very nice secondary analysis. They could have made it even stronger, I think. But so that's my views on this paper at this stage.
Thank you, Professor, for your wisdom. Anybody else would want? Dr. Palaniappan wants to say something.
Yeah, thank you, Dr. Gus, and thank you, Dr. Girija, for putting me through this. My point of view is it has changed the practice over the last 25 years after the PPROM trial came in, because I thought in India, most of our inductions have changed from oxytocin to either a prostaglandin gel or a pessary. We have started using pessaries here as well, but we've used augmentation of, oxytocin for augmentation rather than induction. And that's what the paper has done 25 years, 27 years back. But we have changed over now, and there are very few of us who use oxytocin for induction of labor rather than we use them for augmentation. And we have also moved our way off from oxytocin to that of either the gel or the pessary with prostaglandin. So that has made a lot of practice, though the paper said there is not much difference, whatever, but then we have moved from that to this. And I'm sure the experts here will agree that we have moved off from oxytocin to prostaglandins at the moment. And Prachi well presented, no doubt about the presentation, very clear presentation of the entire study.
But when you have PROM, putting a prostaglandin gel or pessary may not help to the extent that when you use oxytocin, no? Because there's already a leaking there.
Correct, but the question is the pessary and the gels have been quite consistently used even if there is a leak. The gels don't leak out, and there are a lot of studies which have said, oh, still you can use the gel even if you have a PPROM. That's exactly the point of discussion which I just wanted to make out here, Charmila. You brought that out. So Dr. Girija, what is your view on that?
Yeah, see, Professor Palaniappan, we really do not encourage any kind of a gel treatment whenever there's a PROM patient. And then we are caught in the quandary, because then what we do is if there is any sign of cervical change or an uterine activity, then we consider going in directly for using an oxytocin augmentation, because that is shown that the labor has already got induced. Now that particular patient segment where you are not seeing any cervical dilatation or uterine activity, then usually we consider taking a recourse of maybe using an oral misoprostol. Now, this has to be used very, very cautiously, because if you, by any chance, this has been our experience, and Aniket and I have dealt with one such case together, and that really said a lot of thinking after that was, if you have a little action of uterine myometrial contraction or cervical change, and if you are not judicious in using your misoprostol, you may land up in not only meconium stain liquor, but there in this particular patient, we experience amniotic fluid embolism, because there is such a thinning of the lower uterine segment that this can cause. And from that time onwards, we have said a no. Anyways, we feel that C-sections have become quite safe. In case if you fail in doing anything, you might as well consider doing a delivery via C-section, but you will use an oxytocin, and a vaginal prostaglandin gel. Somehow we don't use in a patient of PROM. I don't know what is the experience of the rest, or we also consider using a mechanical dilator. We can use maybe a dilapan or a Foley's catheter for an, for the bulb kind of an dilatation of the cervix. That's what we would practice.
So for all your inductions of PROM, you use Foley's catheter then, mechanical method.
Yeah, it depends. So we individualize a thing depending on the gestational age. Now, when a gestational is remote from term, we are very happily using misoprostol. But when it is near term, then we have the real, challenge. But of course, the case which I am quoting, Charmila,
yes,
I tell you that the misoprostol dose which was used was not right in that patient. Now we have the FIGO guidelines. So if you stick to them, usually you would not have any problem, is what I experienced. But we have to understand that this is an erratic drug in its response. So with a very close monitoring, trying to take into cognizance that there can be any hyperstimulation can occur or fetal distress can occur, we have to be on guard.
Because with the Foley's catheter, you got a chance of increased infection, when there's a PROM there.
Yes.
So that also will cause problems.
Yeah.
And what did they use in this particular study for induction?
Prachi?
They used oxytocin and prostaglandin E2 gel. Two things we use.
Like,
They
did
use
they,
the ET gel.
did they differentiate between the infection rate with prostaglandin gel and with oxytocin or something like that? No.
No,
No,
ma'am.
the infection rate cannot tell here,
Infection.
Prachi. I thought that's exactly the point, and we are quite happy using the gel even for a PPROM. I mean a prom. And what I was just wanting to say is we have moved from oxytocin to prostaglandins. That's exactly what I was just going to say. And that is the practice implication which Dr. Gus was expecting, is what I thought. And so in our practice, we are using the gel, even though there is a leak, and the gels hold very well because the gels are designed in such a way that they don't leak out and come, and patients are lying down, and the gels have been used like what has been happening here. And we have been using the pessaries also now in a prom. And so we have moved from the misoprostol, yes, no doubt about it, oral, and the dosage being 25 micrograms is what we use. So, but we don't have any comparative study to analyze as to which is better and things like that. But we are using the misoprostol, the PGE2 gel, and the pessaries quite well for a prom.
See, logically speaking, the compared to the gel, the pessary would be better because, as Girija was saying, a hyperstimulation, you can just take out the pessary. Probably that will help prevent a hyperstimulation, but you can't do that with the gel. So for a prom, I think probably logically speaking, I think the pessary would have been much better, right?
Yeah, if I can add,
Yes, sir, yes,
sorry, for interrupt. Certainly, when I initially made my comment about this study, I'm talking about the 2022 study. Of course, the HANA trial in the mid-90s had a huge impact on our practice. I do agree with Geertja that from a theoretical perspective, I really would let's prefer the pessaries, and we would see that as a relative contraindication to use the PGE2 gel. And I've certainly seen, but it's never reported appropriately because the numbers, all the studies are probably underpowered, but anecdotally, we've definitely seen significant hyperstimulation with PGE2 gel. And that was not the case with Cervidil. And if it rarely did occur, indeed you can remove it. And so I would strongly urge the use of Cervidil in that case. We just started to have a few months ago. We have this oral misoprostol at 25 mics, and now registered in Australia. And I think that will probably also become an important tool, but I do share also their Geertja's concern that if you have a very unfavorable cervix and you get a significant uterine response, you may get in all kinds of trouble. So I think we would certainly like, it would be if people have a big series from India particularly on the use of low-dose oral misoprostol with outcomes, that would be very publishable. I think the international literature would be very interested to hear these clinical type of experience. Thank you.
Thank you, sir. Dr. Vandana, would you like to say something? Dr. Vandana? Ma'am, you have to unmute yourself.
Unmute yourself, Vandana.
Yeah, Dr. Girija Wagh madam already explained what practices we do follow in Bhartiya Hospital. Like we use, Foley's catheterization and then the gel and the misoprostol sometimes. Okay. So that is what the practice we follow in the Bhartiya Hospital.
Okay. Thank you.
Yeah.
Dr. Bharati Mageshwari, she's there? Okay.
She has logged in.
Madam left, madam left sometime.
Okay.
I think Lakshmi madam, we got a queue now under your guidance. We should devise some project of 25 mcg misoprostol in prom, as Professor Gus has said, and take an initiative of having this trial entire country, maybe even ICOG members, we can do this for us. That would be something which is easily reachable, achievable also.
Shamila, I am here.
Yes, Bharati. Would you like to say something? Yeah.
We are actually using misoprostol, of course, in a PRN cases, as Palayappan has said. Prefer we used to do misoprostol in cases. We have not done though comparative study, but we are comfortable with misoprostol and having good results.
Oh, okay, yeah. Thank you. There's a comment in the chat box that Dr. Manish Pandya is saying we have published a paper on using 25 mics of misoprostol in induction of labor. Sir, you should publish that for our sake. Dr. Manish, yeah. Thank you so much. So can we go on to the next paper? If anybody else wants to comment, we'll take that and then go to the next paper otherwise. Girija will go on.
Yes, yes. Thank you so much, Prachi.
Okay.
Many have appreciated your presentation and keep going.
Yes, so
on.
much.
And have a round of applause to my young
Yeah.
student here.
You did so well, Prachi. Thank you so much.
Well presented. I'll leave you here because I don't have any gynae experience, but I'm happy to participate in further journal clubs.
Yeah. Thank you so much, sir.
Thank you.
Okay, bye-bye.
Thanks, Adams. Thank you.
Aniket, you can go on to the next paper.
So moving from the term prom study, term prom was a huge study of some 2,500 in both arms of study. So coming like exactly as what Isaac Newton said, that we learn a lot by standing on the shoulders of giants. So from this giant study of term prom, we come to a small study, a novel study, unique study. We know letrozole as a drug used for ovulation induction into it. And suddenly while reading about letrozole, we came across this article, which was considering aromatase letrozole as a novel treatment for ectopic pregnancy. And to present this article, which was published in Fertility Serenity 2020, I call upon Dr. Shivani Bhandari, is a second-year resident in the Department of Obstetrics and Gynaecology at Bharti Hospital. So Shivani, you can share the screen and present your journal.
Yes, sir. Good afternoon, everyone. I am Dr. Shivani Bhandari, second-year resident in Obstetrics and Gynaecology, Bharti Hospital, Pune. Would like to present this article in the journal club. Aromatase inhibitor letrozole, a novel treatment for ectopic pregnancy. This article was published in Fertility and Sterility Journal on 1st of July 2020. The ectopic pregnancy is a major cause of maternal morbidity and mortality. The estimated rate of ectopic pregnancy ranges between 1 to 2% of all pregnancies and 2 to 5% of pregnancies achieved after assisted reproductive techniques. The available interventions for treating ectopic pregnancy include surgery and medical management with methotrexate. The medical management with methotrexate has been found to be more effective than the surgical management while maintaining similar treatment success and future fertility. The chemotherapeutic agent methotrexate is known to be associated with significant adverse effects and also leads to increased failure rates, high beta-HCG levels, and progesterone levels. The third generation aromatase inhibitor letrozole has its advantages, including safety, high tolerability, low cost, and minimal adverse effects. The author hypothesized that by inhibiting estrogen synthase, the aromatase inhibitor, progesterone would not exert its physiological role in maintaining early pregnancy, including the ectopic tubal pregnancy. They studied the use of aromatase inhibitor letrozole for the treatment of ectopic pregnancy in comparison with the methotrexate. It was a non-randomized prospective cohort study which was conducted at the University Hospital Minya in Egypt. A population of 42 consecutive women with undisturbed tubal ectopic pregnancies who met the inclusion and exclusion criteria were selected. The primary objective of the study was letrozole, the treatment of ectopic pregnancy, compared with methotrexate, and the secondary objectives were to determine the changes in the biochemical parameters of ovarian reserve by anti-Mullerian hormone levels affecting fertility and the hematological changes in the liver enzymes and the platelet count. The diagnosis of ectopic pregnancy was made by an absence of intrauterine gestational sac on transvaginal ultrasound, the beta-HCG titers beyond a discrimination zone of 2000 milli-international units per ml, and the gestational age of at least 6 weeks before the diagnosis of ectopic pregnancy. The inclusion criteria were as follows: a spontaneously achieved pregnancy between 18 to 40 years of age, and the ectopic pregnancy diagnosis confirmed by the admitting physician. The exclusion criteria were as beta-HCG levels of more than 3000 milli-international units per ml, hemoglobin less than 10 gram per deciliter, a count of less than 1.5 lakh and the elevated liver enzymes, blood urea levels, and the serum creatinine values. This non-randomized prospective cohort study included women with undisturbed ectopic pregnancy who had no contraindications to methotrexate or letrozole treatment. The study had 3 groups, the control group and the 2 study groups. The study group 1 consisted of methotrexate, while the study group 2 consisted of letrozole. The sample size, there were 14 participants recruited in each of the study groups. The surgical group had 14 participants recruited. In the methotrexate group, 2 participants underwent surgery due to hemodynamic instability, and in the letrozole group, 1 participant became hemodynamically unstable and was taken for surgery, and in other, the beta HCG values failed to decline after 4 days of treatment. Hence, an alternative line of management was selected. Thus, in both the study groups, 86% of the population showed a complete resolution of pregnancy. In study group 1, injection methotrexate 50 mg per square per body surface area, a single dose was used. And in study group 2, tablet letrozole 5 mg for 10 days was given. The beta HCG levels were done on day 0, 4, 7, and 14 of treatment. Complete blood count, liver enzymes, blood urea, serum creatinine levels were done on day 0 and day 7. The anti-Müllerian hormone levels were done on day 0 and 3. Included, there was a data which comprises of age, BMI, and parity. Taking into consideration all these parameters, there was no statistically significant difference among the 3 groups. This table shows us the level of beta HCG at different times while the treatment was ongoing. There was no statistical significance between the beta HCG levels on the day of the treatment and at the completion of the treatment. There was a statistical difference in the values when we measured the platelet counts and the liver enzymes. These differences were statistically significant. The levels of the anti-Müllerian hormone were measured on the day of the treatment and 3 months after treatment, which showed no statistically significance. The strengths of the study include, it is the first study on success of aromatase inhibitor letrozole for the medical management of ectopic pregnancy. The complete resolution of pregnancy with decrease in adverse effects seen with methotrexate therapy being a chemotherapeutic agent can be avoided and achieve better biochemical values. The limitations of the study were as follows: a small sample size and a non-randomized study of design. In conclusion, the study suggests that the letrozole has high resolution rate and higher safety profile when compared with the chemotherapeutic agent methotrexate. Letrozole can be a safer alternative to the surgical approach for managing early pregnancy loss. Thank you, everyone.
You can stop sharing. Huh?
Yes, ma'am.
Yeah.
Any questions from the experts?
Palaniappan, would you like to say something? Girija?
Yeah, I know this is a nice presentation. Thank you, dear. And congratulations. My students were quite, sort of stressed out that we are going to present in front of all the national experts, but I am very proud of them here that they are doing a good job and they are doing it in the methodology that we have been teaching them how to present. And this was one study which, sort of we felt that why not, with methotrexate is so very problematic, especially if with bone marrow suppression, and its efficacy is also many times doubted. Why not try something different? But you can see that the study is a very small powered study, very small cases, and there's a lot of ambiguity in the way the patients have been selected and all. So I think we should leave it to the experts to comment and then, maybe take this forwards the discussion.
Dr. Jyoti Bindal, madam, wants to say something. Madam, can you unmute yourself?
My one small, very good presentation.
Shivani.
Yes.
Thank you.
But my one small comment was that in the exclusion criteria, you mentioned that beta HCG level above 3000 units will not be included in the study. Now, if we
Yes,
go
ma'am.
towards the beta HCG chart for an ectopic pregnancy, we do see that at 5 weeks, sometimes it reaches as high as 7,540 units.
Yes, ma'am.
And of course, definitely by 7.5 weeks, it's definitely above 7,650. So what I'm trying to say is that means in this study, you can only include the cases which are probably below 5 weeks. And it's so difficult for a woman to come to us before she misses her period. That means before 4 weeks. So actually
Yes,
the
ma'am.
window available for this study is not even 1 week or maybe sometimes 2 weeks upper. So that
Yes, ma'am.
would leave very few cases for us to, use this drug. That was my only.
Yes, ma'am. Yes, ma'am.
Bharati?
Yes, it's a good informative study, well presented. But of course, we have not tried letrozole, so we have got thoughts, and we will definitely see if there is some scope. Definitely, methotrexate have lots of side effects, but it is effective. We are using it for long time in the medical management, especially if it is indicated. So yes, we will see. And of course, as Dr. Bindal has said about the criteria of STG, so we will see that if we can get mostly patients comes, sometimes they are beyond beta STG 2000, but of course, it is have a good scope to research further. Yeah.
Dr. Vandana?
Yeah. This study's sample size is quite small. It is 14. So we can just take it as it is a pilot study, and somebody can just carry forward this study so that we can get good results with number of sample size or more. That's what I feel. But
actually, what made them choose that number of 3,000? Was it based on something? See, because for the methotrexate treatment, there were lots of studies were done, and then they based that level on that, because the failure rate was much more when it was crossing that 4,000. But what made them choose 3,000 for letrozole?
Maybe they must, as madam said, the gestational age less than 5 weeks, that could be one of the criteria which is not mentioned there. And where the levels of HCG will be less. And that's why they might have taken this.
And as Dr. Jyoti Bindal madam said, we can actually miss these cases very easily, because 5 weeks is usually they come around 6 weeks, and with pain and all that, the symptoms start late. So it has to be like a very high index of suspicion in all the high risk women probably, and then we can try this drug. But though most of our populations come to quite late, and this catching them at 5 weeks, as Dr. Jyoti madam said, was like, right, we will not be we'll be unable to catch them at this thing. But have you tried letrozole in your hospital, Dr. Vandana?
No.
No, you're not right.
No, we have.
And besides that, Dr. Shamila, if even a patient is having less than 2,000 beta STG, so methotrexate is in fact only single injection is also, we have found that's very effective, and it is injectable. So we are more comfortable. Though if letrozole comes in the thought, so we can see. But of course, has to take this medicine for 7 days, what she has given the treatment option. So we have to remain whether it is effective or not. And if it is, we are taking oral, so lots of things on the absorption and all and efficacy. So there are lots of things to see.
See, but if this drug is acceptable, I think it will be a landmark, this thing, because you're having a drug which is not causing a complication like liver enzymes elevation and a problem with platelets, because that some group of patients actually suffer from methotrexate toxicity, which I've seen with ectopic pregnancies also, even at that minimal dose. So if this drug works, it will be a great breakthrough. But we need a bigger study to tell us at what beta HCG to do, and suppose she lands up, like the monitoring has to be a little different from methotrexate then. It will have to be much more extensive, and you have to keep a watch over her, because
always, it is always better we have many options for treatment. So it is always better that if letrozole come in clean and it is effective, and even if for 2,000, then they will try for more beta STG level, then they will do. I think this is the initial study, so that this STG level has been kept for keeping in mind the patient safety. So definitely the good thought. And
so the delegates have to keep in mind, like if you try letrozole, please give us the data also, so that we know how it succeeds in your ectopic pregnancy. So that will form a bigger study Girija, that will be the next study from ICOG, right?
Yeah.
Girija.
Can I say something, Charmila, here?
Yes, ma'am. Yes, ma'am. Shobha,
Yeah,
ma'am,
yeah.
please.
So good evening to all of you. Fantastic case presentations by both the doctors. Very nice. Good afternoon, Dr. Lakshmi. Good evening. Wonderful, wonderful journal club. I just wanted to say here that a possible application of this would be ART cases where the pickup of ectopic is the earliest, perhaps, rather than spontaneous conceptions. So maybe when it is picked up very, very early, that and the other area would be cervical ectopic, where other methods are so difficult to use and surgery becomes the only option. So these two areas is post ART, we have found post ET, they come back very early. There is a very early pickup of ectopic. So maybe some clinical case scenarios, if you can have a specific application of this, maybe that will help in building up data in favor of this drug, since there is so much interest in its efficacy.
Yeah, that's why I said high risk cases, you have to keep a watch over them, and that will be the ART cases, because there we keep a very close vigilance over the pregnancy, the confirmation and the follow-up with, and because you get lots of biochemical pregnancies also, and many times in ART we follow up these patients. So that will be a group, but suppose you pick her up late, and if you give this drug, like, will it be effective? That as Bharati said, we are quite used to using methotrexate for a long period of time now, almost like 20-25 years we've been using methotrexate. So
but
this
if
drug will be new.
Beta HCG is less than 1,000, we get phenomenal success with expectant management.
Yes, yes.
We don't have
There's no need to give a drug at all, right?
So if it's only when beta HCG climbs up and it is increasing that we need to worry about progressive trophoblastic, presence, and then we have to use the drug, of course.
And sometimes with methotrexate, when you give 2 doses, even if it's beyond that criteria level, some patients respond actually. They don't land up with a surgical outcome after even giving methotrexate for a higher dose, a higher level of beta HCG. Girija, what is your thought on that?
See, the HCG level assessment itself is sometimes a big question, because many times various labs will show different studies. There are certain chains in the HCG which may not be detected by certain way of kits which are being used. And we also sometimes have seen that even in a larger number of, in a higher level of HCG, but you have a small size of sonographic, because we have very good resolution machines nowadays. So if the gestational sac is small, we have considered giving methotrexate, which is called as a longer regimen or a multi-dose regimen, and have been able to avoid an unnecessary surgery in that moment. So I think again we come back to the same thing, because most of the studies and experiences are very low powered, and therefore we have to probably do the rest on our own experiences, and then tackle these issues. There wouldn't be a single one golden level of HCG which would help us take this action and take that action.
Yes, I agree with Dr. Varida. And sometimes we have seen in our patients that they come and we have some suspicion, and at that time we are not able to do that particular investigation, or attendants are not there and they are not ready for the surgeries and all. And at that time, as she said, that even little higher beta HCG, we have given the drugs and sometimes they work. But of course, whatever criteria is recommended, so normally we used to follow them so that we can avoid any life-threatening complications and unexpected upset, etc. So that always remains in our mind. Yes.
There's actually a question in the chat box. It's a novel method of combination of letrozole with methotrexate. Will that work?
Yeah, always thought should be there. If there is higher, I think they are trying to avoid the next dose of methotrexate. If we can combine that. Curiosity and research.
Letrozole itself, there's a big discussion going on, and you combine both. And Girija, do you think it's workable?
I don't think so.
Functional impairment and affecting the
Okay.
Any more? Before we come to this
sometimes,
conclusion regarding co-working of methotrexate and letrozole, what happens now? Initially, we had only 2 options with ectopic, either a surgical option or it was methotrexate. Now, at least we have got some drug which can be thought of. Of course, there should be proper case selection before we went into it. And again, with clear of methotrexate what to do, then we have at least got something to think on. And as gradually more and more cases will be done, then there can be use of letrozole. Then the study may be with more amount of beta HCG. Then there can be a study with combination of these things. Till the time we have to keep our fingers crossed.
See, one pharmacotherapeutic principle is if there are two medications with different mechanism of action, level, the receptors where they act are different, then it will make sense to combine, because it might result in reduction in dosage of the toxic one, and it will be safer option for the woman, maybe more efficacious also. Another field of interest is women with pregnancy of unknown location. You know, the beta HCG will be there, but you are simply unable to locate the sac. So our policy is usually in asymptomatic women to just wait it out. We don't really treat them. We just keep on checking them for the sac, where it will appear, you know, whether it will come in the adnexa or not. And in such cases also, suppose there is just one kind of, you know, just a tubal swelling and no sac also, and the uterine cavity remains empty, maybe we should look at drugs like this, because methotrexate we don't give unless there is a well-defined gestational sac. At least I do not give. Unless there is a well-defined gestational sac, I do not justify injection methotrexate because it is a potentially toxic drug. So, but sometimes there is just a mass, you know, adnexal mass, which is not yet showing the sac. So these areas, gray areas of PUO, whether they can be resolved also will be an interesting thing to see.
So we have added another indication, Girija. One is ART pregnancies, and second is pregnancy of unknown location, PUL, where you can try letrozole compared to methotrexate when the beta HCG levels are not so high. Is that right, Dr. Shobha? Should we take that as a take-home message for this?
These are just thoughts, because I also remember coming across this literature, and I remember thinking whether in the discussion part, you know, some thoughts like this, that it can be a solution to more situations than a well-established ectopic. So that is one thing.
I can share an experience from my colleagues, some of whom we have used letrozole, and they are not very happy with the results. So these are again anecdotes. So we really do not know how much we can depend on these anecdotal experiences.
There's another question on chronic ectopic. Can you use this drug for chronic ectopic? They're adding indications to you, indications for the study, Girija, now.
Yeah. But I understand that when we are looking through the journal club, we should see whether that study which has been presented is enough reliable to depend on first.
It's just a thought. Yeah, it's just a thought.
Coming to our mind, maybe. Yeah.
Charmila, another indication I saw heterotropic pregnancy. So
you can't. We can't use for heterotropic pregnancy. Definitely no. That I think we can rule out, madam, because I don't think we can use in a heterotropic.
I think now imagination is running a bit.
Running amok now. Yeah.
I wanted to say something here that. Sorry about that. Just wanted to. Yeah, chronic ectopic cases, you know, can be followed up with some pain medication, etc. Because if we do a laparoscopy in them, usually we end up in removing the tube. Now, we have done a follow-up for chronic ectopic also that do not require treatment because the beta HCG would fall away. So the trophoblastic action is no longer there. So it doesn't justify any medication. But these women usually go into hydrosalpinx or a chronic kind of a tubo-ovarian cystic mass. And that ultimately when they come for, maybe there is subfertility, may or may not be subfertility or infertility, they may require removal of the mass later on. But the follow-up of chronic ectopic, if not operated, is also not very great. It need not necessarily be infertility, but it is not really great. But we can take a
I think we are moving away from the discussion because it's basically on letrozole for.
Yes. I agree with you.
Yes. Thank you so much.
Because there was a question, I thought I will.
Yes. Dr. Girija, would you like to say something before we go on to the third article?
I think we have to, there is a still gap of understanding, and we are looking forwards to a good medical management and approach to an ectopic pregnancy. Something funny which came to my mind, which I must tell you, was It was discussed in the United States. You remember when they were discussing about the management of an ectopic, and one of the politicians there asked, why can we not put the tube, the pregnancy from the fallopian tube inside the uterine cavity? Now, I think, that's something far too different. And recently I had an extremely morbid patient who became pregnant from out of the blue, saying, Doc, can I not take this pregnancy from me and put it in some surrogate? So I think things will go by. Maybe we'll reach to that level when we are now considering so many various vistas of management. But we understand, at least at the end of the presentation that my dear junior colleague here has given, that there is a huge gap still waiting for us to find out what will work best for unruptured ectopic, because we are diagnosing them early, and what would be a solution for a chronic ectopic, which will not cause any tubal stigma, unnecessarily surgeries and things like that. So thank you so much for a wonderful presentation. And I think we can have a round of applause for my dear friend here. Yeah, thank you.
Thank you. Thank you.
So we move to the third case. So initially we had size of, and we're thinking about was the sample size less. And now we have a study where the sample size was more than 1 lakh. So then we have got a study, a whopping study done by the NHS. So what can be taken care of by just having an electronic media? And if you can take back, or if you can recollect the data from the patient, you can get a huge study. For that study, we have got finally, yet very importantly, last but not least, Dr. Shruti Balodia, 1 year and less than 1 year into residency. And Shruti is shouldering the responsibility of presenting the journal club to the ages of ICOG. It's a huge challenge for her, and she will give justice to this study, which is published in British Journal of Obstetrics and Gynaecology in 2020. The study is about conservative surgery for ovarian torsion in young women, perioperative complications and national trends. And we thought of including the study to make it as a mixed bag. When we went through the ICOG journal clubs, there were the theme-based studies. So instead of limiting to one thing, we thought of making a mixed bag where it will give us a good amount of studies and a good amount of different kind of take-home message. Therefore, we have 3 different studies, 3 different sample size to have it for the residents and also for the to get an idea about how journal clubs are written, how cases are selected, how a thesis is presented, how an article is written, and so on. Shruti, you can start your presentation.
Good evening, everybody. I'm Dr. Shruti Balodia, Junior Resident First Year from the Department of Obstetrics and Gynaecology, Bharati Vidyapit, Pune. The title of the article is Conservative Surgery for Ovarian Torsion in Young Women, Perioperative Complications and National Trends. This article was published in the British Journal of Obstetrics and Gynaecology on 13 February 2020, and the references were taken from year 1954 to 2009. Primary objective of the study article was to analyze populational trends in the surgical management of ovarian torsion over time and to identify the predictors of conservative surgery for ovarian torsion. The secondary objective was to compare the incidence of perioperative complications following conservative surgery compared with oophorectomy. The ovarian torsion is referred as the full or partial twisting of the ovary around its suspensory ligamentous structure, resulting in compromise of the ovarian blood supply, which can lead to ischemia, causing tissue necrosis, and potentially resulting in permanent loss of the affected ovary. The prevalence of the ovarian torsion is 2 to 15% in the women who present with the adnexal mass. Although ovarian torsion can occur in females of all ages, it is most commonly found in the women of reproductive age who often desire the potential for future fertility. Oophorectomy was traditionally considered the standard of treatment for ovarian torsion due to the hypothetical risk of thromboembolic events following untwisting of the ovarian pedicle. Ovary left in situ may lead to peritonitis or infection. Hence, the conservative surgery such as ovarian detorsion with or without ovarian cystectomy, ovarian cyst drainage, or oophorectomy were considered. study was a population-based retrospective observational study done using nationwide inpatient sample in the USA over the time span of 15 years in using 89,177 cases of ovarian torsion, which included 23.1% of conservative surgeries and 76.9% of oophorectomies. The women in the reproductive age defined by the WHO, that is 15 to 49 years of age, as well as the pediatric patient younger than the 15 years of age who were diagnosed with the ovarian were eligible for the study. And the women who did not undergo surgery or those with the diagnosed ovarian or tubal malignancies were excluded from the analysis. The NIS nationwide inpatient sample database was used as the base to study as it provided the data regarding patient demographics, operative details, hospital data, perioperative complications. So the results were that performance of conservative surgery has increased from 18.9 to 25.1% between 2001 to 2015, but decreased steadily after the age of 29 and sharply declined after the age of 35. And on multivariable analysis, conservative surgery was more likely to be performed in younger women and those with more recent years of surgery with higher income, with Asian and Hispanic race, and those with laparoscopic surgeries and those who were operated in larger and urban teaching hospitals. Conversely, the Native American women with higher comorbidity status and with larger body habitus were more likely to go for an oophorectomy. On studying this graph, the first graph shows the trends, the comparison of proportion of conservative surgery over the years. That shows that the proportion of conservative surgeries has increased over the years. And the second graph shows that the proportion of conservative surgeries performed in different age groups, which shows there is crowding of conservative surgeries being performed more in the reproductive age groups rather than in the extremes of the age. And to overcome the bias while doing this study, the average treatment effects, the PSIPTW model, that is the propensity score based inverse probability of treatment weighing analysis, was utilized. This model creates a weight cohort that differs based on the treatment type, but it is similar with the respect of the other baseline demographics. And the secondary objective, our secondary objective, which was to compare the perioperative complications, it shows that the conservative surgeries was associated with approximately 30% decreased risk of perioperative complications overall and was not associated with venous thromboembolism or sepsis. So the key results were that conservative surgeries of ovarian torsion is not associated with increased risk of perioperative complications during hospital stay, specifically of thromboembolic events or sepsis. And the rates of conservative surgery and laparoscopy are increasing, but they vary depending upon the patient demographics, hospital, and the geographical factors. Reviews of the literature and studies found no cases of thromboembolism following detorsion with the ovarian conservation. However, there were two prior case reports of pulmonary embolism, both of which occurred in oophorectomies. The strengths of the study were that the larger sample size was studied, and this is one of the largest study to report the surgical management of ovarian torsion. And the nationwide trends to examine the rare events like ovarian torsion was possible because of the study, and it throws light on the clear benefits of the ovarian conservation with regard to the future fertility and hormonal function. Limitations of the study were that details about the intraoperative appearance of the ovary was unavailable, whereas the time from presentation of the patient to the surgery was not mentioned. The surgeon type, whether the surgeon was gynecologist or the general surgeon, was unclear, and the information about the past surgical history especially the prior history of torsion, the menopausal status, parity, the future fertility desires were all unclear. And the surgical details such as amount of blood loss and the operating time was not available. It only captured the inpatient cases, thus the cases which were managed on the outpatient settings with the day case surgeries were missed. And any complications that might have occurred after the hospital discharge or evaluation of the ovarian function during follow-up was not possible. So I conclude, on conclusion, there has been an increasing utilization of conservative surgery for ovarian torsion in USA in recent years. And the study suggests that conservative surgery for ovarian torsion may not be associated with increased perioperative complications. And this supports the performance of conservative surgeries whenever possible in young women with ovarian torsion. Thank you.
Any question from the expert?
You can stop sharing. Huh? Can you stop sharing?
Shruti, stop sharing your screen. Your video requires to be on.
Shruti, wonderful, clear presentation. A massive study, I think. So it should give some clear-cut conclusions compared to the previous article which we discussed. Bharati, your thoughts on that?
Yeah, so Shruti, very beautifully you presented, and good study, of course. As doctor said, that we have kept a different view of the studies in this journal club. And thank you and congratulations, Dr. Lakshmi and Dr. Charmila, to giving me opportunity. So regarding this studies, definitely that they have taken.
1 second, Bharati. Shruti, can you stop sharing?
Yes, ma'am.
So Shruti, please stop sharing.
Yeah.
Yes.
Thank you.
So what I want to say that very beautifully Shruti presented, and they have given very clear message, informative study. And it is clear that in this study, they have taken large data, and they have taken the overview of their own country in USA, what is actually trend. So of course, it is as it is already mentioned that the mode of management or type of treatment in ovarian torsion, it depends on the data, demographic data, as well as patient age and many factors. But it is clear that ovarian conservative surgery is not associated with any harmful effect. So what in our trend in our country, what is trend, other experts will tell. But in our regions, in last 20 years, what we are practicing, we are trying to conserve the ovary, and we have not seen any complications if we have conserved the ovary. But again, the thing is to be mentioned that AMH and ovarian reserve for future fertility, how much it is different. But we mostly all of us, we try to conserve the ovary, we don't remove ovary on the torsion, and we have seen the fruitful cases of fertility and all after that. So this is my opinion. And again, Shruti has very clearly told about the limitation of the study as well as a strength of the study. So it is clear what I feel.
Thank you, Bharati. Actually, what Shruti said was that limitations was the one which actually keeps us a little back, because that they didn't mention about like what type of surgery they did. Did they do something to prevent retorsion of that ovary? How were the pedicles, and was anything done for that? Because what Bharati mentioned was also very relevant. The AMH, the ovarian reserve, after you detort, like was there a lasting damage? Or nothing happened? Because we cannot talk with anecdotes like what Bharati said, like we had good results after. It should be like actually a collection of cases. So that limitation is there, but I think it's a step forward. You need not remove all ovaries which are showing a torsion. You can detort, leave it alone, even if it looks gangrenous, because it does not cause problems as far as this study is showing. So I think people can take it forward and say, do a detorsion and not do a total removal of the ovary, which is totally harmful for the hormonal function as well as for future reproduction. Dr. Vandana, would you like to say something?
Yeah, nowadays women are not ready to remove their ovaries. They want to retain their ovaries. So conservative surgeries are beneficial for them. Even I'm of that opinion.
Madam, there is no logic for removing even ovary on just torsion. And second thing, as Dr. Chamla said, that if there is some necrosis and other things, so definitely we should keep the patient for follow-up, as some studies or some thought that there could be some thromboembolic complications, but we have never seen what in our experience.
I think we're equating to torsion of the testis, and I think that has kept gynecologists from going on to oophorectomy like in testicular torsion. Girija?
Long time back, it's been nearly about 15 years back when this sensibility was dawned onto us. And this was a paper from Israel, which showed that you can, and especially because of the understanding of the ultrasound and the laparoscopy, we realized that detorting the ovary itself would be just enough. Many times I have myself done some mistakes where I've seen that the ovary has turned black and you feel that it must be some innocuous tumor. It is better to take it off, and it just comes out as an hemorrhagic cyst or something where you felt, oh my goodness, why did I take it out? You could have just detorted it, sutured it somewhere, and then things would have been in place. So it's always smarter to, you can even use an intraoperative ultrasonography for that matter, wherein you can understand the circulation, whether it is gone. Many times when you detort, you find that the circulation is coming. One of the important things about ovary is supplied by the direct branch from the aorta. And I think it is essential, like the testis, of course, but ovary is essential for the promulgation of the race, human race. So it's always well supplied with blood supply. The only challenge which would remain is an ambiguous pathology. Like, what is the cause why it has undergone, first of all, become a cyst? And there is somewhere that we still have not been able to break that kind of a thing, whether this is a cancer that we are keeping behind, or whether it is a benign tumor. And we keep on, still aorta classification has come in, but still it is not giving us a lot of insights into this. And therefore we have to keep our things guarded, counsel our patients properly, and take correct decisions whenever we are dealing, especially with ovarian masses. But detorsion, definitely, because I have then after once or two times I've done it even for in pregnancy. Just detort the ovary and tight, and then later on you may consider taking it out. So these things can definitely be considered.
So, but during counseling, that we should tell them very clearly, the patient, that we need a second look again. We can't just say like it will be a total one.
Another thing is it's very easy to counsel usually nowadays patients, because I must thank the Google, because they'll go there, they'll learn, they'll study, they'll come. So sometimes even I write on a piece of paper, endometriosis, go and read this and come. So then, then it's easy for us to counsel them, because they've already broken their head there.
Yeah, and they'll read only about the complications. So it's very easy to, and if you succeed, you will be given the credit for that also.
Correct.
That I avoided all those complications for you. Dr. Jyoti Bindal, madam, would you like to say something? Jyoti ma'am, or Dr. Shobha Goody?
Both are mute. You only can comment.
And I think Dr. Palaniappan also has gone.
Yeah, I think so.
Yeah. Okay.
When we were discussing this case, we did ask Shruti regarding a question that what will be easy? Will it be easy to remove the ovary, or will it be easy to conserve the ovary? And what was your take, Shruti?
That it is easy to conserve the ovary.
She's modified her answer.
See, if you have a big cyst there, and it may again undergo torsion, no? So what will you do? Aspiration, or you will do a cystectomy? That's the next question.
We do aspiration, ma'am. We will prefer to aspirate the cyst fluid.
But Girija has put a thought, no, it may be malignancy also. If you aspirate, you're going to spill the tissue inside, cells inside.
Yes. Yeah.
So
what is better? Tight rope and take a call.
Because anyway, whatever you do it in bag. Don't do it outside. Don't do it in the free peritoneal cavity. Put it in a bag and just take.
Removal of a cyst will be difficult, or removal of the whole ovary will be difficult.
That's for Shruti or for me?
Shruti ma'am, of course, Shruti. So you know what we discussed was, no, what appears easy may not always be right.
Removal
So,
of the cyst is easy or removal of the ovary is
Cyst is
easy?
difficult.
Difficult is
Here,
cyst.
Shruti, it's always easy to remove the ovary because it's just as a pedicle, chop it and take it off, don't bother. But if you're going to remove a cyst, it may bleed. You know, it may bleed, it may spill. And you are always worried, am I keeping the active ovary behind or not? Have I taken away the functional cell itself? You know, see, all these questions are there. Plus, if you're going to do a laparoscopic, let's say coagulation, you may injure the healthy ovary. You may reduce the ovarian tissue completely. Then the question arises, what's the point? So then if you ask us, again, I will go back because we have, for the first decade, I'm practicing now 30 years, for the first 10 years of our life, of our practice, we were removing the ovary. It was easy, simple. With laparoscopy and ultrasound, we started realizing, no, we can do ovary conservation, which is important, okay? So naturally, Shruti belongs to the current generation, and maybe she will have gene sequencing and things like that to help her diagnose malignancy, non-malignant conditions more than us. We are
at this point of time, what will she do?
Yeah.
Before gene sequencing comes. Shruti? See, ovarian cystectomy, as Girija said, you have the problems of spillage, you've got the problems of bleeding, and you may actually injure the ovaries when you're using cautery to stop your bleeding. But conservationists, you can't just detort and leave that cyst there. Suppose it's a big cyst, you may need to remove it actually. Okay, so at the end of it, oophorectomy is easier. That's what she's saying. But you try to conserve.
Yes.
Is it worthwhile going for a laparotomy if you feel that you'll have those complications, Dr. Girija?
I would always vouch for a laparotomy.
Yes, yes.
Because we are having wonderful incision sense, suture materials, healing, everything, infection control. So I would still, whenever it's coming, and especially an ambiguous diagnosis of ovarian tumor, open would be a better approach because we can avoid all these problems.
See, when you put a laparoscope and you see a suspicious mass and you don't know whether it's a malignancy or a benign tumor, and it's undergone a torsion, actually, if you go for a laparotomy, you can save the ovary much better compared to doing a laparoscopy, because you're clear, all your doubts will get cleared off when you're opening up. In a laparoscope, even if the vision is good, you will not know like whether all these complications can happen. So that's easier actually, because the expertise of the seeing all the lab videos do not go with the idea that everybody can do that type of lab surgeries. It has to be the expertise.
Having said that, Charmila, we have done some wonderful small dermoids laparoscopically, and the women have conceived. Then even Aniket and I have actually done one terrible Glanzmann's thromboasthenia patient who had a massive hemoperitoneum with, you know, a platelet count of only about some 8,000, 9,000 under platelet transfusions. We went inside with a scope and cleared her peritoneum, started her on OC pills. That was long time back. Sometimes God gives you a lot of, you know, courage and helps you also in dealing with these cases. But then, as I told you, that we have to be very careful in such decision making.
Dr. Shobha, ma'am, she's joined back.
See, about large ovarian masses, what we have done commonly is always do a diagnostic laparoscopy and pick up any fluid which is there, or pick up the saline washings for cytology and send, and then see if there is a cystectomy feasible without rupture of the cyst. And if it is not possible, if we feel that the cyst might rupture, then we put a small Fenton steel incision, because once we have done the laparoscopy, we are very sure, and then we can actually place the cyst just below the incision maybe, and we get away with doing fairly small with a small incision, because we bring the ovary into that incision and we can do a very beautiful repair also, and we can do an orchidopexy also. So it is nice to have a control laparoscopically and minimize on the laparotomy incision. Then that classical meaning of laparotomy being a midline need not be followed. You can put a small incision Fenton steel, which we are very used to. And, with good anesthesia, I think it is very possible. Recently, we did recurrent mucinous cyst adenoma in a 19-year-old who whose engagement was, just 1 month away. And she came back with a recurrence. I had only done the primary one and I had to deal with the recurrence as well. And the first time around, we had done a laparoscopy and she was concerned. So I said, no, this time I'll peel the cyst wall under a direct vision. That is another concern with ovarian cysts, that if we are not thorough with the removal of the cyst wall, then recurrence is possible. So this time I removed the whole cyst wall and then I have done a very good suturing, because suturing also laparoscopically is, we are not that good at it. We have not been doing that many to do a good job. So when it's a young girl, I think it's better to give her the best. And as everyone is opining, a good open surgery with good standards really gives a very good outcome. She came recently and she's doing extremely well. So
thank you.
Yeah.
I want to share one, different approach which we had taken for one girl. She was a 22-year-old student studying in Pune. And she felt that she is having a tight abdomen because she was doing a lot of gymming. And then suddenly she came to me saying that I'm having pain. And I said, let's get a sonography done. And it was a massive cyst, simple cyst of the ovary reaching up to the Xiphi sternum. But the sonologist, being my own sister, I knew that she will look at everything thoroughly. And this was definitely such a large clear cyst is always benign in a young girl. So then we planned her for an open surgery where we took a very small fanel steel incision. The cyst was coming under the incision. We stabilized it with an external hand and then put in the laparoscopic suction cannula inside, which is very small. Sucked out the entire fluid. It was about 3 suction jar full of fluid that came out. And then this did the cyst wall excision, sutured the rest of the thing, and everything went well. Now, again, this is an anecdote, but sometimes you can avoid a big incision or the spillage that you're scared of at the laparoscopy. And, generally, but then I have also landed in a big soup in such a situation, wherein a 35-year-old woman, thinking that it is a large cyst, sonography was done somewhere else. I didn't want to spend her money again. And I decided to use the same policy. But it turned out to be a mucinous
adenoma.
Yeah, mucinous adenoma. And it was so stiff and solid, we had to extend the incision. I had to take a Maillard's incision, take it out. And unfortunately, later on, and I was definitely worried. So I decided to try to use as much as less spillage as possible. It turned out to have, a malignant potential. It was not a completely malignant tumor, but it had a malignant potential where the woman had to undergo later on chemotherapy. So we have to, borderline I thought I must share with you because we can land up issues otherwise.
Somebody is mentioning Charmila frozen section. So I just wanted to put on across that we do frozen section for all of them. Every single
even here in our Bharti hospital, we definitely do a frozen section. And we are very blessed with the pathology support system. Only thing is it does take, frozen sections take minimum 30 minutes. It's not very easy to get it done.
And what goes along with frozen section to have an onco person standby. Because without that, we can't, you can't have a positive and then not have anybody to complete the surgery.
Madam, what are your thoughts on detorsion, Dr. Shobha Gudi?
Yeah, detorsion. Okay, so couple of bad experiences also when we had to do a revision surgery for when we did detorsion. See, it's very important to make sure that the tissue has not become devitalized.
But how do you make sure that?
That is very challenging. Actually, there is no certain way. So if there is a change in color and the change has to revert back, that it has to change color after detorsion considerably. It should start looking as nearly as possible to the neighboring tissues. And if that doesn't happen, you should take a second look. I mean, you should think about whether you are going to leave, because at that particular stage, nothing will help, because sometimes they used to advocate intraoperative ultrasound with the Doppler, Doppler probe, and then you can see whether there is blood circulation is restored or not. But even if blood circulation is restored, if there is tissue necrosis, it is not going to become alive again.
Madam,
so
actually, this study is very clearly saying you detort the ovary, you don't wait for it to change color.
No, but
That's
why
what the
so?
study, because they're saying even if the color is not changing when peroperatively, post-operatively,
It
there's
will
no
change.
problems with
Correct.
this ovary at all. And they have done a massive collection of data for in this study. It's not
I heard
less
part
number
of
of cases.
it.
They said you
Yeah.
detort and leave it alone. And you need not wait for to see whether viability is happening or not. They're saying it will happen in the future. And they're showing very good results. Aniket, is that right? Or Dr. Shruti?
Yeah, I was also listening into the results actually.
Madam, no,
Yeah.
that paper they put up where they've done the analysis of the study, they put it very clearly. They're detorting the ovary and they're not waiting for it to show viability. They're
Okay,
just
then
leaving
let
it
us-
alone and it has gone on to do very well. That's what I understood.
They had only detortion the ovary and removed and into it. And there was no need of doing any intraoperative ultrasonography to confirm the viability. And in our practice,
let me understand here. After detortion, they have to do the cystectomy, no?
They are doing the cystectomy, madam.
They have to do,
cystectomy is different. So instead of
Cystectomy
removing
they are
the whole
doing,
ovary,
but they are not
cystectomy
waiting
has
for
to
the
do.
color to change. That's what I meant. They're not waiting for the color to change.
But they have to do
Way
the
back.
surgery.
No, way back. No, if there was going to be a torsion of the ovary, then the choice for the regarding, it can be gangrenous. So remove the whole ovary. That is not just.
Yes.
You can remove the cyst, and however bad the the remaining fallopian tube may be to see, you can leave it away. That is.
Okay, see, Charmila, there is a workaround that. See, what can happen is because see, at that stage, the woman or the girl is under general anesthesia, so we cannot ask her. So this thing has to be discussed with the family earlier itself, that whether we are going to conserve or remove the ovary. We will take some pictures also and we'll discuss with you and we'll give you the option of conserving and follow up. But she may require another intervention if things are not going well.
This study has said very clearly that is you detort all ovarian torsions. All ovarian torsions. And if you see a cyst there, you remove the cyst or do a cyst aspiration and leave it alone. And what we were talking is, but even if it's like that, and you have to counsel the parents and the girl that she will need a relook if there's going to be a problem later on. That's what we said. But in that study, they have not clarified that whether they were asked the patients that they have to come for a relook if there's a problem. Aniket, am I interpreting it correctly?
Yes, ma'am, very correctly.
Yes.
And the study had mentioned the limitations very clearly regarding, because it was a study which was going to be done on the sample size and data which is going to be available in electronic records. So they had regarding knowing what was the
low AMH.
There were no
I believe
photographs
that this is a prospective study, isn't it, Aniket? So a prospective.
It's a study. It is a study which was done around 15 years, and they took data from the NHS. So all the data
it
is
a
going to be there
prospective cohort study. Let me understand. It's a prospective cohort study. It will have its own principles of recruitment, and there will be a protocol, okay, in which all this will come. So what we are getting a lesson is such things can be done within the purview of a clinical trial. Because if we try to do it on a case-to-case basis, then we become, independently responsible for that case.
Yes,
and the family also has to accept the outcome.
Actually,
then
this is not this is not a prospective. I think it's a retrospective collection of data. It's a retrospective collection of data, and they made it very that is what the surprising result of this study is. That is, they have just blindly done a detorsion for all the ovarian torsions which happened.
And then
they have not mentioned about the surgical details of what they did and what they did to prevent a retorsion. They have not mentioned. They have not mentioned like whether the patient came back for a relook to know like what's happening, because there was no follow-up also. It was just a collection of data, but that is giving us a great idea that you can detort ovaries which are looking very bad, leave it alone and then watch for it.
No, we do it also in our practice. The only problem comes when there is a lot of discoloration. That is when we feel worried about the outcome of leaving.
That worry, we need not worry. That's what they're saying, madam. Yeah, you need not worry. And but we came with a I think Girija discussed that and said, but we will counsel our patients saying that this looked really bad, but I've left it alone because they can do well. And then you can come back, we'll check it out whether it's working. And probably if she's in the reproductive age group, an AMH and an ovarian reserve, all that can be done in the follow-up to know how she's faring. But this study has not mentioned all that, but it's giving us an idea that you can detort
It's
badly
certainly
looking
food for
ovaries and
thought.
do it
Yes,
well also.
correct.
That's what
The
the
study aim was to study the national trends. So how the trends behaved in USA over the initially it was about removing the ovary, and now gradually they have come to conservative ovary. With conservation, initially thought complications of thrombosis, of perioperative sepsis have gone away, and how they have changed the conservation even for older women. Initially it was, for younger women and older women, let us be very much worried. Don't think of malignancy more, and how conservation has been a game changer on national basis.
Yes.
So that is the
good
concern
thing.
about the case.
It is a happy thing which has happened.
The two plus points of this study is it gives us an insight. It is important that you document your experiences, and therefore you'll have a large amount of experience, which we are always crying in our country that we are doing so many patients, but we are not documenting anything. But the other pitfall of the study also is that the documentation is not completely foolproof, because it is not giving us many answers also.
Yes.
So,
See, Girija, what we can do is this: from ICOG, we can have a registry of ovarian torsion. And all of us
Madam, we say any of these questions.
Third idea out of this journal club.
We should have.
Each paper is generating one idea for ICOG today.
One registry. In this year, we start a registry, and we see this study can pick up the protocol kind of thing. We can have it formulated and floated, and let us see what comes out of it.
When we discussed study now, we came, so this study, they have made a huge publication. It's a publication in the British of Obstetrics and Gynaecology, solely on the basis of data which is recovered from electronic media. That is what we discussed with Shruti. So they came publication even without really having any prospective seeing any patient. But then it is still important. We do learn from history, we do learn from data, we do learn from statistics.
Correct.
Though has
You
got
are right, Aniket. See, the thing is we have to report what we are doing, then it will get picked up by one of these studies. If we go on publishing, then it will
I
get
agree
picked
to
up.
you, Dr. Shobha, when I was reading about bimanual comparison for prevention of PPH. This was in about 120 years back. There was a gynecologist in Europe who did bimanual comparison for 3 hours. 3 hours he was holding that woman and he did not allow her to die. So, he just published that case. So it's there. You've done something and you've written it somewhere. It helps the next generations to, follow. That is what we learn from those experiences.
It all starts from a small dot somewhere, and we should see. Suppose somebody tells us that be very that is, you can leave the ovary behind even if it looks gangrenous. I think it adds value, because next patient will be saving her ovary if you can do that to her. So, and because that study has said very clearly, all the clinicians thought only for young women, you should do a conservative surgery. And for women above the age of 35, it's okay to remove the ovaries. But we know that the ovaries being there for at least for 60 years is quite good for the lady. So that thinking also we can change now. Age 35, if it looks benign, leave it alone. If it looks malignant, then think over it. Otherwise, it's worthwhile detorting and leaving her alone, even if she's older. That's what the study is saying very clearly. I think we can base on we can do a prospective with this, because it's a retrospective collection, and probably a prospective. This thing will tell us like what helped and what did not help and all that. So Girija will formulate the third study also.
That's what I was suggesting, because ovarian torsion are cases of emergency.
I'll ask Shruti to do it. Let Shruti do it for us.
So it will become difficult to generate a study. We can have a registry of it, just like we have registries for other emergencies like eclampsia, like amniotic fluid embolism. They have registries. So like that, if we can have, maybe that will also make sense. Anyway, this is real food for thought.
Yes, all the three studies are like giving us food for thought. And I think that was the reason Girija chose all these papers, right, Girija? All have some meaning and something for the future, right?
Yes, thank you so much. It was actually a joint decision taken by Dr. Vandana, Dr. Aniket and me as to what we are going to present. And as I must tell you that Dr. Aniket looks after our postgraduate teaching training, and the entire PG section is looked by Vandana. So, credit goes to both of them for staging this show here today and ensuring that our students perform well. I think Shruti, you're presented very well, so we can have a round of applause for my dear Shruti also. And this definitely is going to give a lot of encouragement, because otherwise in our institution, we keep on, sometimes ragging them when the PG program goes. So they are going to enjoy this particular accolades and appreciations coming from the national fraternity, and they will definitely do much better. Thank you so much, Charmila, Lakshmi, for giving us this wonderful opportunity. And inputs by Bharti. Hi, Shobha Gudi madam. Jyoti Mindal madam has gone away. You must all know that Jyoti Mindal madam is a vice chancellor of the university in MP, a very, very learned stalwart. And you all are blessed to have her here in this session, giving her inputs and listening to you.
Congratulations, Dr. Girija. Wonderful presentation by your students. Really proud of, and very good selection of papers. We really enjoyed. And thank you, Dr. Shamila, for conducting in very interesting way. You have, creating the discussion with good questions and all. And Dr. Lakshmi, hats off to you for doing daily good ICOG programs. Very interesting. And we all are attending. So thank you very much.
Unstoppable Lakshmi ho gaya uska.
Lakshmi madam, are you there?
Become Lakshmi Express, Nagpur Express.
Lakshmi Express.
Nagpur Express.
Actually, there are two questions in the chat, not questions, two comments in the chat box, and they're talking on usage of misoprostol for induction of labor, Girija. Dr. Dr. Pratibha from GMH Osmania Medical College, Hyderabad, has done 1,000 cases of induction of labor with misoprostol.
Wonderful.
Yeah, so I think we'll take that as also as a pilot study for our study, Girija, hopefully. And Dr. Manish Pandya
has retire from active obstetric life, and then we'll do this.
Yes, Lakshmi madam will help us there. Dr. Manish Pandya said he has published a paper on usage of 25 micrograms. Yes, ma'am. Both papers, one on 1,000 cases and the other on, I think I did not mention the number of cases. I think only that much we have in the chat box. Thank you so much for all of you for joining.
With the low back pain. So here are some basic exercises which you can do at your home without any equipment.
Who's that? Aniket, you can actually give the vote of thanks.
Yeah, it was really a great discussion, and it was a privilege and honor. And I can say thank you on behalf of all the 3 residents. It was a different experience altogether. We do take their journal clubs in our institute, where they have got a set of people who do assess them, and we do send a Google form for assessment and take a feedback, and then give them a debriefing after it. But presenting it on a national platform is altogether a different ballgame. They were very much stressed, they were worried, but they were also upbeat. They are a bunch of highly enthusiastic people who were running around here and there. Initially, they were a little bit worried on that, how will they present it? But then they had a very good helping hand from Nimbargi madam. Dr. Shirish is the other person who looks after the statistics, and he is the also lecturer at our end, who did give them huge inputs. And they are going to be a different person altogether after this. And we are thankful to ICOG and the experts and the international experts for giving us a platform. Thanks, Satan.
So now each one of them have to become ICOG fellows.
Yes.
That is what, after their post-graduation, they have to join this college.
Yes.
Yeah. They have to become members.
Indian college, yes.
They have to become members, yeah.
Yes.
MICU.
Thank you so much. I would like to thank Dr. Lakshmi
Thanks a lot.
madam.
Thank you, everyone.
Yeah. I would like to thank Dr. Lakshmi Shik. Yes, ma'am. Yes.
Dr. Palaniappan is praising the lovely discussion. Thank you,
Yes.
Palani.
Now he has come back again. Yes.
Thank you so much, Dr. Lakshmi Shikande, madam, for giving us this opportunity of conducting the journal club. Thank you so much for all the academic inputs from such great experts and the coordinators, Dr. Girija Wagh, Dr. Aniket, Dr. Vandana, Professor Gus, who joined us from Adelaide, Professor Palaniappan and Professor Bharati Mageshwari for your inputs. A special thanks to Dr. Shobha Gudi and Dr. Jyoti Bindal for joining and giving your inputs. I'd like to thank all the 3 young presenters who did extremely well, Dr. Prachi, Dr. Shruti, and Dr. Shivani. Thank you so much. You did so well. I'd like to thank all the delegates who have joined and made it a great discussion point. Thank you so much. And I'd like to thank Tech Support for your great support, as well as Anilima from ICOG office, who always coordinates for us so lovely always. Thank you so much.
And please bless our students for doing good work.
Yes.
Yeah,
Like to
you will
thank,
pass first attempt.
a special thanks to Dr. Anikit because I troubled him so much. I kept on asking. Thank you so much for your coordination. Thank you. Thank you,
Good,
Dr.
somebody could
Girij.
trouble him. Good, somebody could trouble him.
Everyone, and
Can we stop the
congratulations,
recording?
Madam.
Yes, ma'am. Chalo, see you all.
Thank you, ma'am.